So I should welcome everyone to the COVID Neuro webinar. This is, I think, our 5th webinar now, looking at neurological associations of COVID-19. And today I'm chairing it, as always, but we have Professor Elizabeta Mukatova-Ledinska and Professor Kameshwar Prasad. Do you guys want to both say hello? Elizabeth, you shouldn't hide yourself quite yet. We'll because we're just all gonna, there we go, great. So do you want to say hello to our audience, which is growing? People are filtering in.
Hello, I'm Elizabeth and I work in Leicester. I'm older psychiatrist and I work in the Young Cancer Dementia Service here in Leicester. Great.
And Kameshwar?
Yeah, I'm Kameshwar Prasad. I'm Professor of Neurology and earlier Chairman of the Department of Neurology at All India Institute of Medical Sciences, New Delhi. And my research interests are neuroinfections and stroke through meta-analysis, clinical trials, and other methods.
Great, fantastic, thank you. So I've just got some introductory slides just to introduce the whole series, as it were, and then we'll come on to the talks. And this, as I said, is our 5th of these webinars. We're hosted by the Global Health Network, which promotes knowledge exchange, training and professional development, and process improvement. We have up to 500 people on the Zoom webinar, and then we also have people who are following by Facebook. Now, the first thing we always ask you to do is to, let's check out that the chat function is working. So I'll just pause that for a second so that I can see what's going on. And so if you look at the bottom of your screen, you'll see that you can chat. And what I'd like everyone to do is just press on the chat and say hello, tell us where you are calling in from, and tell us how many of these webinars you've been to, whether this is your first or second or third, and any other messages you'd like to share with us. So send those messages in. There's Bernie from Washington, DC. That's great. We're always interested to see where people come from. We usually have every continent represented. Who else have we got? Yeah, all sorts of people. Great. So, and we'll be using the chat function later on to take questions. So as people are talking, you can send in your questions if you like, and we'll have questions and answers after each of the talks. Okay, so let me reconnect with this. It's funny, however many times you do Zoom meetings, it's always a slight fiddle. Here we go. You can also send messages via the Twitter. My Twitter thing is @RunningMadProf. So I'm here at the University of Liverpool and the Walton Neuro Centre, which is an NHS trust that caters to the population of the northwest of the UK. And I'm heavily involved in infection research. And I head the Brain Infections Group in Liverpool, which covers a range of disciplines. And you can see here the disciplines we cover and also some of the leaders, various group leaders. I'll just mute, there we go. And we host the Brain Infections Global Consortium, and the Brain Infections Global website is on the Global Health Network website, so you can find it there. And we have research collaborators all around the world. We have training through the website. These are just some of the stats. They're a little bit out of date now, but you can see we have lots of people visiting and members of our group. We also do training. We have a neurological infectious disease course that we run every summer. That's an in-person course. And in addition, we have e-learning modules which are freely available online. And in the Brain Infections Global website, when this pandemic started, we set up the COVID Neuro resource and the COVID Neuro Network. And the resource is a website that shows you all the latest publications. As you know, it's almost impossible to keep up to speed with the literature, but this makes it a bit easier because all the relevant neuro papers are pulled through to this website here. And then we also have the COVID Neuro Network. And at the start of the pandemic, we modified some of our case record forms, which we use for other brain infection studies, so that these can be used to study patients with neurological disease associated with COVID-19. And you can download these freely off the website. And we did this because the literature was coming out thick and fast, but a lot of it was a bit confusing because people were recording things in different ways. So the case record forms also include some standard case definitions that you might find helpful as well. Then we pulled all the literature together about a month or two ago, all the COVID neuro literature, and published this in the Lancet Neurology. This was in press, it's now published. And the case definitions are also there if you're interested in those. And then what we did was contact all the authors who'd written about their patients. It was about 900 patients in total, and said, do you want to include your patients in a meta-analysis that we're doing? So we are pooling together data from all those patients, and then also data from people who've been collecting data but haven't yet published it. And we have more than 2,000 patients now that we are analysing and writing up. And if you have patients that you'd like to include in this meta-analysis, then get in touch. Okay, that's the background anyway. So we're going to move on now and hear our first talk, which, as I said, is from Dr. Elizabeta Ledinska. And she is going to talk about mutant responses to COVID-19. And this is less about viral mutants or human mutants. It's more about some of the more the mental health aspects and aspects relating to that. So I'll hand over at this stage.
Well, thank you very much indeed, Tom. I see that plenty of people, participants who have joined us today, it is their first webinar. So it would be right for me also to comment that this is my first webinar, and it is very different experience to when giving talks face to face. And this is actually the life that we're all facing at this moment. Declaration of interest, I'm an older psychiatrist. As I said, I'm not a geneticist. And one of the most appalling statements that you'll hear today is that I have very limited involvement with COVID-19 patients today. So this will be a very interesting journey for all of us. And I'm also looking forward to see how it would end up in the following 10, 12 minutes. When I was invited to give this talk, I really was didn't know a lot about what the journalists have named the long COVID, the consequences of mental health post-COVID. And that coincided with our Prime Minister visiting Covert, which is a small village on the outskirts of Leicester. And then he went in his speech to thank the 11-year-old ones to their contribution to NHS saving lives, then moved on to Harry Potter, sexism, Rule Britannia, etc., ending up with the mutant algorithm that has had an impact on their grades. So that is actually where the title of my talk derives. It is the mutant responses to COVID. This rambling, as the journalist named it, coincided with the famous jumping the fence. And there have been quite a lot of speculations whether this is a post-COVID symptom of spatial neglect, impairment of judgment, etc. But I'm not going to go into this. I just want to reflect on another statement that came from the States, from the American counterpart, about the counting of COVID-19 victims. I think that this actually slide summarizes the state of our own attitudes, mental state, the confusion and anxiety that the pandemic has brought to all of us. But my talk today is around the long COVID-19 symptoms. I have been quite surprised that we're not getting many people post-COVID in our mental health services. I've asked one of my colleagues, geriatricians, because I'm an older psychiatrist, what is happening? We had an influx of a lot of older people who have succumbed to COVID-19 symptoms, and they have interestingly survived, not only died as we're bombarded in the journals, but he said that these people are in the health care chain. They go in and out of acute medicine, and they are treated for their psychological symptoms on acute medical wards, irrespective of whether it's geriatric medicine, ICU, neurology, respiratory medicine, etc. This coincided with the drastic drop of admissions and urgent care that we observed in our mental health services. I have to draw your attention that this was happening somewhere in March and April. Only a few minutes ago, my colleagues told me that actually the admission rates have increased, and they have increased because of anxiety, because of domestic violence, because of a range of behavioral problems that the community services have been able to intervene and cope with pre-lock. So this is actually a very interesting situation that we are faced with. But I've chosen 3 case vignettes to present to illustrate actually the extent and the variety of mental health problems that we see in our routine clinical practice. First of all, I'll start with Gordon, 64, who was COVID positive, and his life, interestingly, changed overnight. And within 12 days, he became from physically fit, mentally capable man with a very happy family life to a widower. His wife died from COVID. He spent 3 days as an inpatient, but the consequences are lasting even now for 5.5 months after his episode of COVID. He complains of fatigue, anxiety, depression. He's listless, lonely, isolated, with flashbacks on his inpatient stay. And I have to stress that his inpatient stay was very brief, about 3 days in total. He had no major changes in his mental state in terms of improvement over the last 5 months, despite being on antidepressant, seeking help for his post-traumatic stress disorder. He also lost 2.5 stones over these 5 months. And as you can see, his scores for anxiety, depression, chronic fatigue, post-traumatic stress disorder are extremely high, and they have stayed very high over the last 5 months. But his cognition, as measured on our cognitive battery of ACE3, are actually very good. He scores 97 out of 100. What I found very interesting is that instead of the usual duration of consultation, which is with our service is about 1 to 1.5 hours, my consultation lasted long, and it was around thanking me for seeing him face to face. He stressed the importance of someone to talk, very beneficial and making a huge difference. So this is Gordon, who tested positive, and this is actually his journey with mental health problems over the following 5.5 months. There is Martin, who is 75 years old, who is tested negative, but he has got a very different expression of his mental state, psychological functioning. There have been no concerns regarding his mental health or cognition between April of this year, but his life changed with overwhelming anxiety, agitations, concern about the infections that resulted in delusional beliefs of him being infected, in also infecting his family. He also lost a lot of weight during this period. He was reassured, he was prescribed antidepressant therapy medication, but nothing actually helped. He is now an inpatient on one of our acute medical wards. All investigations, including blood, CT brain scans, are normal, but Martin sadly is not functioning well. And the third case vignette is Ian. And Ian, I think, is a typical representation of what is happening with our people with memory problems who have been in prolonged isolation. He has got primary progressive aphasia, but he was functioning quite well until the epidemic. He was self-caring, a very jolly chap, looking very well after his well-being and the well-being of the family. But the pandemic actually brought some other issues for him, becoming what the family says an old and grumpy man, not very pleasant, for him having frequent showers, washing his hands, being frightened to go out. And although we have tried to regulate some of these behavioral problems with antidepressant medication and counseling, nothing sadly has helped. And he was similarly to Martin, SARS negative. So basically, I'm presenting 3 case vignettes with very different clinical symptomatology, but something they have in common is the anxiety, the overwhelming anxiety that has spread to all of us. So how this anxiety actually fits in with what is out there in the literature. We have just submitted a revision of a paper about review of the mental health issues post-COVID and during the COVID epidemics. And I would like to draw your attention that in the convalescence phase, that is where Gordon, the first person that I presented, fits in. There is significant depression, post-traumatic stress disorder, post-viral chronic fatigue. But the 2 non-COVID positive patients actually are still stuck in what I would call the acute phase. They haven't actually moved in their mental health journey. They're still suffering from depression, from dysphoria, panic attacks, phobia, obsessive behavior, and even psychosis. The psychosis is actually very interesting, and yesterday one of my colleagues asked whether we have seen psychosis as a first presentation of COVID-19. Here in Leicester, we haven't actually seen that, although we've got a patient that we're suspecting that maybe had a psychosis as one of the initial symptoms. And his case or her case, it would be in the range of autoimmune psychosis. But we're seeing a lot of this differential diagnosis, and Martin, the second case presentation, actually will fit all of this as a primary psychosis or organic secondary psychosis. But he also does not fit all the criteria, because in all of this, one of the criteria is relatively brief duration, 1 to 3 months. And in case of Martin, his psychosis is still lasting even now after 5 months. So what does it bring the stress and the SARS infection together? So I've tried here to summarize it in a very simple way. And I think that both the stresses, irrespective of whether it is mental health stressor or it is a viral infectious stressor, they have the same mechanism of increasing the cytokines, the inflammatory markers, with the well-known cytokine storm that's described in SARS. But also inflammatory markers are increased in stress, leading to anxiety and depression, inflammation, pain, and pain in itself actually contributes to the decrease in BDNF, and the BDNF is directly involved with the expression of acetylcholine. So it is no wonder that a number of our patients also demonstrate with subjective memory problems and even profound dementia. Their dementia actually progresses further. But also these neurotransmitters and cytokines influence the autoimmune system, and IgGs and IgMs elevations are both found in SARS-CoV infection, and also as a result of stress. One very interesting and for me very important issue is the impact that both the neurotransmitters, the cytokines and hormones are having upon the endocrine system. Strangely enough, recently we have had people diagnosed with type 1 diabetes in their late and mid 60s and 70s. Which is not a characteristic for type 1 diabetes. And I just wonder whether this is actually a result of both the stress or the inflammation, maybe. Also, similarly, we're getting an influx of referrals from people with underlying autoimmune illnesses, such as multiple sclerosis, rheumatoid arthritis, lupus, with subjective memory problems, anxiety, and depression. So this actually brings me to what we have learned so far as psychiatrists. We've learned, at least I have learned, that the mental health problems are not restricted only to people with already enduring mental health problems, but actually it is the general public. And we're seeing quite a different population in our clinics, which may require configuration of our mental health services in terms of integrated care models, both in primary and secondary tertiary care, to include mental health. Another issue is about us as professionals, since a number of people, majority actually of people, will not be tested for SARS, and we don't know actually what would be the longer term outcomes of the viral infection, and especially about the long-term outcomes from the asymptomatic patients, which actually brings me to one topic that is very close to my heart, and it is whether we should actually thinking about bringing psychiatry back to the mainstream medicine, and is the future neuropsychiatry. It's interesting because I've started my professional journey as a neuropsychiatrist, becoming a psychiatrist and then older psychiatrist. And I'm increasingly actually finding myself that I'm going back to my professional roots of neuropsychiatry. So we're close, I'm nearing the end of my presentation, and just briefly to tell you what is happening with Gordon, Martin, and Ian. Gordon continues to be with prolonged bereavement with post-traumatic stress disorder, anxiety, and depression, isolated and lonely. We have referred him for cognitive behavioral therapy, but he is afraid that it will be delivered via phone, the new way of working. Martin remains confused, anxious, with delusional beliefs regarding the pandemics. Neuroleptic medication, antidepressant, hasn't actually helped to move or decrease his abnormal beliefs. Ian continues to be an old man, withdrawn, with obsessive compulsive traits and agoraphobia. And now I would like to thank Tom and Eva Maria for inviting me. And also I would like to thank my own bubble, professional bubble of colleagues who have supported me through my personal lockdown in Leicester. Because some of you may have heard, Leicester was the first town that was put in lockdown. And I just wonder whether that also may have had consequences to our own mental health as professionals and white. And at the end, I'll just leave you with a thought about the future that Tennessee Williams said. The future is called perhaps, which is the only possible thing to call the future. And the important thing is not to allow that to scare you. And I think this is actually the saying that has kept me, and I hope that it has helped some of my colleagues to survive the real atrocity of what we have witnessed, both as on a personal level and as professionals. Thank you.
Thank you very much for that. Very, very interesting. I must admit, when knowing that you were going to be talking about mental health, and when you started off with talking about our Prime Minister and the President of the United States of America, I did wonder where we were going to be going. Let's stop your screen share now so that we can see the three of us a bit more clearly. There we go. And yeah, well, fascinating, some really interesting case studies. And interesting that two of them, as far as you know, hadn't even been infected with this virus. It was just all about the anxiety relating to the general environment, I suppose. Do you feel that there are elements, you know, that we've overdone it as a society? If we're creating this kind of terror in people, do you think we've gone wrong somewhere along the way in our messaging?
Well, it is a difficult, actually, question. You know, I'm a neurobiologist, neuroscientist, and I would like actually to understand the origin, the etiopathogenesis of all of this. Because in psychiatry, I think that we have moved away from the medicalization of the mental health problems. But it is interesting, actually, and very important to bring back all that together. And what I found very useful for me as a clinician is that they share or may share very similar pathogenesis, and we should not be differentiating them. I personally feel that those with much more profound infection may have got a different way of different severity of their mental health symptoms. But it is still, I think, very early days to comment on that.
And we've got a question here, so do please post your questions in online, everyone, via the chat function. Question from Joachim Serejera. What type of follow-up do you plan for these patients?
Well, that is actually a very interesting question. They will require a lot of input. The presentation, the case that I presented, he has been with the health system for the last 5.5 months. He has had some counseling with the post-traumatic stress disorder services over the telephone, which did not prove to be sufficient. I have referred him for cognitive behavioral therapy. And I have offered actually appointments with our service because for him himself, you know, talking therapy would be beneficial. And he says just talking to somebody who is not his own family means a lot. We hope that, you know, maybe this will change our working practice about the use of liaison psychiatry on our medical wards. Because in his case, I was actually specifically asked, what are the facilities for people like him to be referred to mental health? And we have actually liaison psychiatry services. I used to be a liaison psychiatrist myself when I was working in Newcastle. And that is actually where we should aim to be much more present and much more involved.
Kameshwar, have you seen patients like this? I know you're not a psychiatrist, but are you aware of the increasing psychiatric disease, maybe among COVID patients, but then also among the general population, as we've seen here?
Yeah, you are right. We do see patients who become more anxious. They are depressed, particularly after going through an experience of being in ICU or even otherwise in isolation room in the hospitals. But I generally refer these patients to our colleagues, psychiatric colleagues or neuropsychiatrists. And personally, I know a couple of patients who had problems which persisted for weeks, but then they recovered.
Yeah. And do you think, Elisabetta, I mean, the other thing I was wondering, these patients who are not infected with COVID-19, but they're just responding to this bad situation in terms of the pandemic, I'm just wondering how it compares with other previous times when as a society we've been very anxious, maybe around the times of the sort of 9/11 terror attacks, 7/11 terror attacks, or wars, or previous pandemics. Do you think is there anything special about what's going on now, or is this just what we would expect?
I think that maybe we have forgotten how it was. I remember the New York attack. It didn't provoke such anxiety as this one provoked, because this is a global thing. And maybe the images, the constant bombardment for the magazines, journals, newspapers, it is everywhere. You know, also our mental health services and health services in general appeared to respond in a different way. And also the policies are changing, the recommendations are changing, which contributes to a lot of anxieties. It's interesting, you know, I've stressed that at the beginning of the pandemic, there was a decrease in admissions and urgent care. And that is actually quite well known. In wartime, mental health is not a problem. It is survival is a problem. And I would like to stress that this reminded me to my training. As a part of my training, we had war psychiatry. I don't know actually whether it exists actually as such anymore. But at that time, you know, it was about resilience, building resilience. I've remembered the variola vera epidemics in the 70s, early 80s. Not many people will remember it, but I remember it as a child. It didn't cause such anxiety as this one has, because it was contained in a different part of the world.
Yeah, I mean, it's so you're saying during initially with the COVID-19, a bit like the beginning of a war, people are just surviving, and then once they've survived, that's when all the anxiety kicks in.
Yes.
Some interesting comments here online from people about various aspects. Julian Tang, who I think is a respiratory doctor in Leicester, saying, is that right? Which is where you are. So it's one of your colleagues asking a very difficult question for you.
Yes,
now,
I'm prepared for him.
Oh, right. Is he always difficult? His comment is it's always difficult to relate virus-related versus host immune responses to psychiatric manifestations, which I guess is true. Let's see what else. Do you want to come back to that briefly?
No, it is true, and it is interesting actually that we have started thinking on those lines, especially in relation to autoimmune encephalitis, autoimmune psychosis, and actually yesterday, it was the very first time we have asked for a battery of autoimmune responses to be done. I don't think that it is very common among psychiatrists to ask for NMDA receptors, D5 receptors, etc. But it seems that maybe we should be thinking on those lines as well.
I mean, we certainly, for us, from our perspective, working on brain infections and seeing the range of presentations with autoimmune encephalitis, you know, there's quite a lot of interest in linking up with the psychiatrists. Julian, forgive me, he's a virologist, he says, not a respiratory doctor. I think I knew that. Shahanaz Chowdhury with a couple of comments. Other events have never had such impact as COVID-19, particularly on the socioeconomic condition. I guess that's true. We've had things before, but maybe not as big as this. Okay, finally, because we're going to move on in a second, but Isaac Egeza with a question about what are some of the measures that can help in addressing COVID mental health effects on healthcare workers? Have you had 3 tips for healthcare workers or anyone to protect their mental health in this terribly difficult time? What would they be?
Well, that's a very good question. I think that, mental health has been actually affected seriously, both with SARS, with MERS, and now much more profoundly with this among the healthcare, and especially those that have worked directly with in ICU and very difficult cases. I think that
top tips. What should people be doing to protect their mental health?
I think that maybe building the resilience and be prepared for the future. Looking back, actually, maybe it is too late. We will have to be dealing with the consequences.
Don't be saying that. Well, this is meant to be a positive experience for people. You're telling me hundreds of healthcare workers around the world who, at lunch, they've got their sandwich, they've got their cup of tea, they think this is going to be interesting, and you're telling them it's too late.
I said I haven't got
All right.
the answer for that,
Kameshwar, what do you do to keep your mental health? How come you're still smiling? What do you do to look after yourself through these difficult times? Are you on mute, I think? You need to unmute. Maybe that's the trick. Just mute yourself. And stick your fingers in your ears.
One thing we do is regularly do yoga.
Yoga, good.
Every day in the morning. And second thing, which of course is subject to whether you have time from a webinars or not, but music is another thing which helps.
Yoga, music, great, thank you. And we're going to move on.
Say actually what I personally found was to keep my routine unchanged, going to work and meeting colleagues. Thank you.
Yeah, no, I think that's very helpful. So let's move on. Thanks, that was absolutely fascinating. Kameshwar Prasad then at the All India Institute of Medical Science. We're currently both on the WHO group looking at COVID neurology. And he's going to pull together for us today some of the lessons from the literature. Thanks, then over to you. We'll just help you to share the screen.
First of all, I must thank Tom and Eva Maria to have given me chance to speak to this august audience. And I'll start with a little bit of our own experience and then go on to what the literature says about COVIDs. Let me try to share my
screen. That's right. Yeah. I'll stay with you till you're sharing. Otherwise, it feels a bit rude. It's like abandoning someone on the stage.
Yeah. Sometimes I don't know.
We had a little difficulty earlier, I know.
Yeah. Okay. I think
looks good.
Yeah.
Perfect. We can see that.
Right. Very good. Right. So I'm going to start with a very preliminary analysis which we did for a presentation comparing what kind of stroke patients we were admitting prior to COVID in 2019, and now after COVID has struck us between March to May 2020. And one, of course, observation is that number has gone down, and that's expected because there are a lot of restrictions imposed on movement and even admissions of non-COVID patients. So I'm sure non-COVID patients are finding it difficult to get treatment. But keeping that in mind, if you look at the age structure, in the COVID period, we have younger patients compared to 2019. There is no change in sex distribution. Surprisingly, we have proportionately more hemorrhage. It may be something which we need to continue watching. But as far as treatment is concerned, thrombolysis and endovascular thrombectomy, there is a trend of change, but not statistically significant. Numbers are very small, so we can't talk about statistical significance. But essentially, one can see that type of stroke has a tendency to change, but certainly age group has changed towards younger people. And then we started debating that, look here, COVID is causing this stroke, younger people are getting struck, they have no risk factors, and so on. These debates often are very, I would say, excited and very engaged kind of debate, a very engaging debate. I would say sometimes I have to put my epidemiology hat and ask questions. And then I ask the questions, look here, what you are saying is, COVID is a risk factor for stroke. If that is the case, let's apply the same rules as we apply for hypertension. if COVID is a risk factor, then prevalence of COVID among stroke patients should be higher than prevalence in general population. So I showed to them, there was a sero survey in Delhi. And for those who don't know, it happens every month, starting from July, first week of every month, there is a sero survey on random population of about 15 to 20,000 people in Delhi. And they use ELISA, which is developed by our National Institute of Virology. And they look at presence of antibodies in the population. So in people who are at high risk for stroke, you can see above 50, there is 31.2% seroprevalence. And we don't look at only August, but here it is almost March to August. If you look at the prevalence among stroke patients of COVID, which is through RT-PCR, so there are differences in the tests also, it's about 27.5%. So I asked my colleagues, look here, if it is really a risk factor, then we should have higher prevalence among stroke patients in as compared to general population. So there will be debate about, these are two different tests. So I said, which one is more sensitive? Well, we probably, ELISA is more sensitive, RT-PCR is sensitive to the 60%. So I said, then it is underestimating the prevalence among the stroke patients, which means actually, if we add about 25% more, even then we are just close to 32%. So which gives you odds ratio of 1. So why do you say COVID causes or maybe a risk factor for stroke? So they will say, no, maybe, it's a trigger. People are already predisposed, but maybe it is a trigger. I said, okay, then we need to study a little more about this. And then I got a little bit excited about looking at the literature, whether there is literature about proper studies which will tell us that COVID is a risk factor for various neurological syndromes. So we registered our systematic review, in Prospero, as people do. So in the interest of time, I'm not going into the details of methods, but those who are interested can actually download it from Prospero and read it. But basically, we just tried to look at the phenomenology, what is the prevalence of various neurological manifestations. And there was a secondary objective. We wanted to see whether serious patients or severe patients have different kind of picture as compared to the patients who are not severe. So we will tell you very briefly, but interesting thing is, we plotted the number of publications which are coming and the kind of neurological features which are described. So you can see we started describing neurological features in January, then it went on, and then very well-known paper by Tom and Elul, they added a number of dimensions to this. But we are reaching a plateau. As you can see, by July, I think we have reached a plateau. Hardly any new syndromes or new symptoms are being added. But I'm aware that a group of experts from 3 countries, Iran and Singapore and one more country, they are going to describe something which has not been described as yet. So I will, I am not going to disclose this at the moment, but efforts are going on. But I think we have got probably all manifestations which are there. And this is the way the literature has been increasing in number. And now coming straight away to the results. So one problem which we faced was that neurologists like us, and I'm also guilty of doing this at times, we describe 3 cases, 5 cases, a case series of maybe 10 patients, 20 patients, but we don't tell you, or we don't describe, and others also didn't describe in many cases, what is the denominator from which these 5 cases have come up or 10 cases have come up. So if denominator is not there, you can't find out percentages, and therefore we were not able to include those studies while we were calculating the pooled prevalence. But just for take-home message from this, is actually the most common. If you consider fatigue as a neurological symptom, which certainly I do and many neurologists do, then you see sometimes they are described along with myalgia, sometimes separately. That's the most common, most prevalent symptom which we found from the literature. And then the next comes the taste impairment and smell impairment. So ageusia and anosmia are probably also close to the top. And then comes features which are central nervous system like confusion, disturbance of consciousness, headache and dizziness. And then you go down to neuralgia, sensory impairment, seizures 1%. But what becomes apparent is that as you go down below dizziness, the number of studies are drastically down. From, you can see 20 studies, 10 studies, or at least 5 studies, you see 2, 3, 4, and the prevalence also goes down drastically. So it's from 7% to 2%. So there is a threshold below which there is a sudden drop. There is one study which has described agitation, corticospinal tract signs, and hearing impairment. These single studies obviously can't be put into meta-analysis. The meta-analysis we did is using R, which, as you can see, this is about all the studies describing headache, comes to about 11%. Not going into details of this, but when you come to neurological syndromes, basically 4 syndromes which come up very well, apart from skeletal muscle injury, is total stroke, Guillain-Barré syndrome, movement disorders, and encephalitis. But if you allow single studies, not a meta-analysis, you will find neuropsychiatric disorder, dysautonomia, restless leg syndrome, and dysexecutive syndrome, which are described. Now, obviously, there are a number of studies on psychiatric features. So probably this is unusual heading neuropsychiatric disorder, which has been used in one study, but many studies describing psychiatric features are already there. So as regards stroke, we come down to a prevalence of around 2%. And probably that is what is realistically correct, but maybe more studies and Tom's individual patient data meta-analysis can throw some more light on this. When we compare this to other systematic reviews which have been published, and we are still working on it, our target date of submission is about the end of September. You see, we have added 12 neurological symptoms or signs in our systematic, compared to August 2020, which added 12 symptoms and signs. We are probably going to include them in all our meta-analysis as far as possible. So these 12 will be added to the studies which are published in July or June or May. Each study or each systematic review is adding about 13 to 15 neurological symptoms or signs, and then I think we have reached a plateau. So I won't go into the older studies which started appearing in May with about 8 or 9 neurological symptoms added to the previous ones. Now it's about 10 and 12, and my guess is we are reaching very close, very soon to a plateau of what our neurological involvement is there in COVID. There are a number of neurological syndromes which have also been described. I already talked about the ones which are commonly reported. But one point which I want to share with you is interesting that if you look at some symptoms in severe and non-severe COVID, there is a difference. And as you expect, disturbance of consciousness will be more common in severe and skeletal muscle injury. Surprisingly, smell and taste impairment is less in severe. So obviously, the reason is that severe cases were never reporting smell impairment because they are overburdened with more serious problems. So I think because of that, there is underestimation of smell and taste impairment in severe patients. So what do we learn from this? I think if we are to describe, if we are to describe neurological manifestations, we have to have a systematic way of collecting the data using a form which I must inform you, WHO is developing, Tom is and myself both are working on it along with several members. And if you have a form and systematically collect and ask these questions, maybe after these severe patients recover, you ask them about anosmia, they will tell you, yes, my smell is coming back now, I had lost it, but they didn't report it at the time of admission because they were more concerned about more serious things. So what do we learn from the literature? What I think is that we are still in the descriptive phase or discovery of symptoms and signs of neurological involvement in COVID, but we have to move to analytical phase where we start asking questions. What is the evidence of association? And properly select patients. Maybe large vessel disease has association. So we should do that focused on large vessel disease, large vessel occlusion, and then demonstrate that there is a high odds ratio and indicating association with COVID. That kind of studies, to my knowledge, I haven't seen as yet. So that is something which we need to think about. And whenever we describe or report, I think I have certainly learned that I must give a denominator. Out of how many patients we saw, these 5 are patients of myelitis, or these 2 are patients of Guillain-Barré syndrome. If we don't do that, I think we miss a very important piece in the, somebody who's doing meta-analysis will not be able to include it. So apart from this, we are still learning. I may say that we are missing something which will be apparent maybe later on. But all that is happening is acute symptomatology. Chronic phase will tell us what are the sequelae of COVID infection in terms of neurological involvement in future. Thank you very much.
Thank you, Kameshwar. Let's rejoin on the videos there. And well, that was really interesting. I mean, some rather controversial stuff at the start. I hope the team will help Elisabetta rejoin us on the video. Yeah, I mean, what you showed at the start was really interesting, comparing, looking at antibody prevalence in the population and saying that is higher than the number of stroke patients who have PCR positivity. I mean, do you really then not think that stroke has increased in association with COVID-19, or are you just teasing us?
Well, I love to see a graph which goes on describing how COVID epidemic fanned out and how stroke incidence went on along with that same time. So I hope to see a graph which will, it will be a sort of a kind of evidence. It will be more ecological kind of evidence, but still we need to see that graph to see whether incidence has increased. From what has been described, young patients without risk factors getting stroke, which are not, we never expected, there is certainly something to do with COVID. Yeah. But probably we are not selecting right kind of patients, and that's why the prevalence is coming very close to.
Okay, but I mean, you have to, you have to remember the antibody test of the population is testing whether they have had any exposure at all over, the past 3 or 6 months, which is very different. The PCR test is just telling you whether those stroke patients have got virus on board right now when they present to hospital. And especially since the feeling is that the stroke presentations actually are really a post-infectious thing. Many of those patients, even if they were infected with COVID-19, may not still have virus on board, a month or so later. Yeah, interesting. Let's see what we've got. Some questions that have come in on the via the various chat functions. Actually, there was one earlier that I wanted to put to you, Kameshwar, as a neurologist, and it was about somebody who's seen a patient, Forhad Uddin Hassan Chowdhury in Bangladesh, is managing someone who is COVID positive for the virus, SARS-CoV-2, and has Guillain-Barré syndrome, and wants to know if you've seen any patients with Guillain-Barré and COVID, and whether you would manage them differently or just the same as any other GBS patient.
Yeah, we manage no differently for COVID-associated Guillain-Barré syndrome than the ones which we did earlier. One question which one of our colleague raised is that, we use corticosteroids in COVID. Is it contraindicated if patients have Guillain-Barré syndrome? I would say no. I don't have time to give you reasons for this, but this is a myth that corticosteroids causes harm to patients with Guillain-Barré syndrome. Certainly there is no harm. So I will not hesitate to use, if I am required to use corticosteroids, like dexamethasone from published reports, as you know. But otherwise, the management is very similar.
Okay. We're going to have to keep things short because time is getting close to the 2 o'clock. Eckhart Steffenberg, who's a great fan of the webinars, I think he makes all of them, but he came late to this one. But good to see you, Eckhart. And he's wondering whether people are thinking about pre-existing, vulnerability factors, pre-existing brain injury, neurodevelopment conditions, substance use, misuse. And I guess this could apply to thinking about both the psychiatric conditions and the neurological presentations. Let's just have a brief thought from both of you on that. Do you think those could be important risk factors for psychiatric disease during this pandemic, first of all, Elisabetta?
Can you repeat the question? I'm sorry.
That's okay. How much will pre-existing factors contribute to vulnerability? So maybe pre-existing substance abuse or misuse?
Yeah. I think that from what I'm hearing, there must be some modifiable factors. And I was very intrigued by your presentation, Prasad, about the incidence. And I was just wondering whether meditation also may help, music, etc. So there can be modifiable factors, but also it is the personality traits that we bring in, our resilience that I actually touched on as well. Building the resilience throughout our life, also the educational background. I think those are very important issues that we should actually work on.
What do you think about that, Kameshwar, pre-existing vulnerabilities?
No, my sense is that pre-existing will certainly predispose to or make one vulnerable to develop more neuropsychiatric sequelae or maybe neuropsychiatric manifestations. And we, as you know, as I mentioned also, that we have to see post-COVID. If we have data on pre-COVID, post-COVID, and during COVID, one can see whether there is increase in incidence of neuropsychiatric features and sequelae. But my guess is, yes, I think they will be more vulnerable.
Yeah, yeah. And then just thinking a bit about your presentation, fascinating, especially showing how the number of new factors described has gone up. New neurological features goes up as more and more of these publications come out, but seems to have saturated. But I think, a really important message about trying to include denominators when one can, which helps us understand whether we're really seeing something new, or it's just, a change in the way things are presenting. I think in this respect, Gideon Mbiti sends in a really interesting comment or question about the young stroke patients. Are we really seeing more young stroke, or is it just the way that, is it an ascertainment bias because older patients are not getting to the stroke units because of the way you know, older people in general are not having such great access to hospitals, certainly in the UK. I don't know, how is that in India? Has there been a difference in terms of what kind of people are admitted to hospital?
Yes, as I showed, yes, younger patients are getting admitted more often, and perhaps more frequently they are getting some kind of preference, which was always there to some extent, because we always have shortage of beds. But I think this COVID situation definitely has introduced selection bias. Mm-hmm. And we are certainly admitting younger patients more frequently, are being more concerned about this as compared to older people. So there is definitely a factor of selection there.
Great. Okay, well, we're just about at time now. In fact, if anything, we're slightly over, which we try not to do. But just in terms of wrap up, let me just share with people. Ooh, that doesn't look right at all. Let me share just some closing slides that we usually show. Are you seeing my screen at the moment?
Yes.
If I show that, are you seeing the slide? Yeah. Brain infections global slide.
Just switch out of presenter mode.
Okay, am I doing the right thing or not?
Just if you just click switch and then
switch displays like that. There we go. Just to remind people, thanks Helena, about the Global Health Network website. Somebody has asked about where you can see the previous webinars that you've missed. So on the website here, if you go on the news and events tab, and then it drop downs and all the previous webinars are there. So if you want to look back at some of the highlights of the previous speakers that we've had in previous talks, then you can find them there. And also if you like your webinars, but you want something a bit more relaxed and not quite so manual, I thought it was quite relaxed today, but we do once a month, we do the Scouse Science webinar where we get together a scientist and also a celebrity, and we just have a general chat about the latest developments in the COVID pandemic. But time now for me to first of all thank Helena and the team at the Global Health Network for putting everything together today, and to thank our two speakers, Professor Elizabeta Mkitova-Ledinska and Professor Kameshwar Prasad. And thanks very much to all of the guests for joining us. Goodbye now.